This is the third session that describes the mechanics of breathing. The learning objectives are to review the mechanics of breathing, list the factor affecting breathing, explain lung compliance, describe the airway resistance, and describe the clinical application of today's lecture. Remember that the respiratory cycle is composed of short inspiration, longer expiration, expiratory pause where the glottis is closed. The respiratory cycle has a rate. The rate of the respiratory cycle is about 12 to 16 cycles per minute. Remember that inspiration is an active process. There is contraction of the diaphragm and the external intercostal muscles, increasing the transverse, the anteroposterior, and vertical diameters of the chest. The increase in the volume of the chest is accompanied by a decrease in its pressure. So the air will move from the high atmospheric pressure to the low pressure inside the chest, and this is inspiration. Expiration, on the other hand, is a passive process, where there is relaxation of the already contracted muscle. There is relaxation of the diaphragm and the external intercostal muscles, accompanied by the elastic recoil of the lung and the chest wall. Thus, there is decrease in the transverse, anteroposterior, and vertical diameters of the chest. The decrease in the volume of the chest is accompanied by increase in its pressure. So air will move from the high pressure inside the chest to outside, which is expiration. Now, what are the factors affecting breathing? Factors affecting breathing include the respiratory pressures, certain physical factors, which include the alveolar surface tension, the intra-alveolar dependence, the lung compliance, and the airway resistance. In this session, we'll describe the lung compliance and the airway resistance, as the alveolar surface tension and the intra-alveolar dependence already described with the respiratory pressures earlier. Now, what is compliance? Compliance is defined as the change in the volume per unit change in the descending pressure, and it is expressed as the changes in the volume divided by the changes in the descending pressure. Remember that any hollow elastic structure tends to expand as the pressure inside it rises and to collapse as the pressure inside it drops. Actually, it's not just the pressure inside the structure that determines whether it will expand or collapse, but actually the difference between the pressure inside and the pressure outside is the main determinant. This pressure difference is called the descending pressure or the transmural pressure. Now, we can say that the compliance of the lung is expressed as the changes in the lung volume divided by the changes in the descending pressure, which is the difference between the pressure inside and outside the lung, which is the difference between the pulmonary pressure and the pleural pressure. So the equation for the compliance of the lung is expressed as the changes in the volume of the lung divided by the changes in the transpulmonary pressure. When the pressure inside the hollow structure is greater than the pressure outside, the descending pressure is positive and the structure expands. If the reverse occurs, the hollow structure collapses. When we are talking about the compliance of a structure, this means we're talking about its expansibility, distensibility, and stretchability, the ability of this structure to expand. And we all know that both the lung and the chest wall have the ability to expand. And why is this? This is because they are viscoelastic structure. They contain elastic tissue, and their volume can be changed with the change in the transpulmonary pressure. Knowing this, we have to ask ourselves an important question. Is there a relation between the elasticity and the compliance? And the answer is, there is an inverse relation between the compliance and the elasticity. To understand this relation, you have to know that elasticity of the structure is the ability of the structure to resume its normal shape, volume, and size after being stretched or compressed. To apply this on the lung, it's the ability of the lung to resume its normal volume and size after being stretched. So when we say that the lung has a high elasticity, this means the lung has a high elastic recoil, high ability to recoil back to its original volume, high ability to collapse after being stretched. And if the lung is having a high elasticity, high ability to recoil, high ability to collapse back to its original size, this means its compliance is low, because compliance is expansibility, distensibility, or stretchability. So this is the inverse relationship. So remember that as the elasticity increases, the compliance will decrease, and vice versa. The diagram that represents the compliance of the lung relates the changes in the lung volume to the changes in the transpulmonary pressure. The relation is recorded by changing the transpulmonary pressure in small steps during both inflation and deflations of the lung, and allowing the lung volume to come to a steady level between the successive steps. The relation between the pressure and the volume during inflation and deflation is not a straight line, but it's a hysteresis slope. You can see that the lung volume changes during expiration is more than that during inspiration. That's to say, the lung compliance during expiration is more than that during inspiration, and this is the hysteresis slope. The difference between inspiratory and expiratory air inflation curves is due to the surface tension. During lung deflation, surfactant molecules become closer together, causing further decrease in the surface tension of the fluid lining the alveoli, and this makes the lung more compliant. The characteristics of the compliance diagram of the lung are determined by the forces that cause recoil of the lungs, and they are the elastic forces of the lung tissue itself and the surface tension of the fluid lining the alveoli. The significance of the surface tension can be studied by comparing the compliance of the lung when filled with air with the compliance with lung when filled with saline. In case of saline-filled lung, there is no air-fluid interface, and therefore the surface tension effect is not present and only the tissue elastic force are operative. The pressure needed to expand the air-filled lung is about 3 times as great as the pressure required to expand the saline-filled lung. So we can conclude that the surface tension force represents about 2/3 of the force tending to collapse the lung. This means that when the surface tension is eliminated, the lung is far more compliant, that's to say, more distensible. Note that the compliance of both lungs together in a normal adult is about 200 milliliters of air per 1 centimeter of water. That's to say, as the pressure will change by 1 centimeter of water, the volume of the lung will be changed by 200 milliliters of air. The compliance of both lung and chest wall together is about 110 milliliters of air per 1 centimeter of water. Now, what are the factors affecting compliance? Factors affecting compliance may be related to the lung compliance or the chest wall compliance. The factors that affect the lung compliance are the surface tension of the fluid lining the alveoli and the elastic forces of the lung tissue itself, while the factors affecting the chest wall compliance are any factor that affect the elastic forces of the chest wall. Now, coming to the factors that decrease the compliance, we said earlier, decrease in the compliance can be at the level of the lung compliance or the chest wall compliance. The factor that decrease the lung compliance could be restrictive lung disease, such as pulmonary congestion and fibrosis, or deficiency of surfactants, such as in the respiratory distress syndrome. Other factors that decrease the chest wall compliance could be related to skeletal muscle disease, such as myositis and poliomyelitis, or in cases of arthritis and kyphoscoliosis, or in obesity. The factor that increase the compliance is either related to the lung compliance or the chest wall compliance. Lung compliance is increased in emphysema and old age, where the lung lose their elasticity as a result of destruction of the elastic tissue and the wall between the alveoli break down so that the alveoli are replaced by large sac. The chest wall compliance increase in athletes. Now coming to the important question. What is the functional significance of abnormally high or abnormally low compliance? Low compliance indicates a stiff lung, as in fibrosis, and it means extra work is required to bring in a normal volume of air, while a highly compliant lung indicate poor elastic recoil, such as in emphysema. In this case, the patient will have no problem inflating the lung, but have extreme difficulty exhaling air. And in this condition, extra work is required to get air out of the lung. Always remember that compliance is the ratio of the volume change with the unit change in pressure. We have static lung compliance where there is no air movement and it represents the lung compliance alone. And we have dynamic lung compliance where there is air movement and it represents the compliance of both the lung and the chest wall. Now coming to the last factor that affects the mechanics of breathing, which is the airway resistance. Airway resistance is an important factor that affects the mechanics of breathing and the flow of air. The flow of air in the respiratory passage depends on both the pressure difference and the resistance. The flow of air depends on the pressure gradient between the atmospheric pressure and the intra-alveolar pressure. Poiseuille's relationship earlier showed us all the factors that affect the resistance. The resistance depends primarily on the radius of the conducting airways. The resistance is higher in the medium-sized than the larger, then at last the small-sized airway due to their large surface area. Note that the flow of air is directly related to the radius of the air passage and inversely related to the resistance of the air passage. So increasing the radius is accompanied by increase in the flow of air, while increasing the resistance is accompanied by decrease in the flow of air. Factors affecting airway resistance include the amount of secretion inside the airways. As the amount of secretion inside the airways increases, as during inflammatory disease, this will increase the resistance to the airflow. Lung elasticity. Decreased lung elasticity, as in emphysema, increases the airway resistance. Lung volume. Airway resistance is inversely related to the lung volume. Airway resistance is low at high lung volume and high at low lung volume. As when the lung expands, this causes traction on the wall of the airway, increasing their diameter. Bronchial muscle tone, which is affected by the autonomic nervous system. Parasympathetic stimulation causes bronchoconstriction and increased mucus secretion, while sympathetic stimulation causes bronchodilation and inhibits mucus secretion. So it's important to know that bronchoconstriction can occur due to parasympathetic stimulation, that's to say, vagal stimulation and presence of acetylcholine. Also the presence of histamine or the fall in the partial pressure of carbon dioxide in the alveolar air. On the other hand, bronchodilation occurs in cases of sympathetic stimulation of beta-2 receptor, presence of nitric oxide, or the increase in the partial pressure of carbon dioxide in the airway. Now, what could be the clinical application of today's lecture? The first clinical application of today's lecture is the condition where there is high compliant lung, such as emphysema, which indicate poor elastic recoil, as the elastic tissue has been damaged as being overstretched by the chronic cough. Patients with emphysema will have high compliant lung, have no problem in inflating the lung, but they have extreme difficulty exhaling air. In this condition, extra work is required to get air out of the lung. Another clinical application of today's lecture is the condition where there is low compliance of the lung, which indicate stiffness of the lung, such as in cases of fibrosis. And it means extra work is required to bring in a normal volume of air. Another application of today's lecture is the treatment of bronchial asthma. Recalling back what we discussed in this lecture, we know that the sympathetic stimulation produces relaxation of the bronchial smooth muscle by stimulation of beta-2 receptor. This results in an increase in the airway diameter and decrease in the resistance to the airflow. That's why beta-2 agonists are useful in the treatment of bronchial asthma. Lastly, have you ever wondered how did you take your first breath? Well, After normal delivery from a mother who has not been depressed by anesthesia, the child begins to breathe within seconds and has a normal respiratory rhythm within less than 1 minute after birth. This prompt breathing results from the slight asphyxiated state incident to the birth process and the sensory impulses that originate from the sudden cooled skin. The infant who does not breathe immediately becomes more hypoxic and hypercapnic, which stimulate the respiratory center and causes breathing with an additional minute after birth. The first inspiration of a normal neonate is extremely powerful, usually capable of creating 60 mm mercury negative pressure in the intrapleural space, allowing lung expansion. By this, we finish the third session that describes the mechanics of breathing. I hope that you enjoyed it. Thank you.